Good morning, Professor Bonham, and thank you very much for your presentation. My name is Giancarlo la Marca. I am the president of the Italian Society for the Study of Metabolic Diseases and Newborn Screening. Let me give you some information about the Italian program for newborn screening and some information about our newborns. As you know, our Italian population in 2020 was a little bit higher than 60 million, with a little bit more than 400,000 newborn. We had a reduction of 13% in the last 4 years and higher than 30% in the last 12 years. As you know very well, the history of newborn screening dates back at the beginning of the 1960s, when Robert Guthrie developed a very easy and cheap test for the detection of the most frequent aminoacidopathia, the phenylketonuria. Early in the 70s, also in our country, newborn screening for PKU started. In Italy, neonatal screening is mandatory by national law since 1992, and this law entered into the force and remained active up to 2016. At that time, in 1992, newborn screening was mandatory for the entire neonatal population only for 3 disorders: phenylketonuria, congenital hyperthyroidism, and cystic fibrosis. And at that time, in 2016, we had 32 newborn screening centers in the entire country, covering and serving for less than 15 newborns per year per lab. In 2016, what is normally considered and called expanded newborn screening, especially by means of mass spectrometry, through some pilot project, was covering only 50% of our neonatal population. In the same months, the law number 167. Today, newborn screening program is considered in our country an essential public health service, covering up to 40 disorders, including aminoacidopathias, organic acidurias, urea cycle defects, beta oxidation of fatty acids, galactosemia, and biotinidase. Moreover, the entire cost of the program is covered by central government, up to 26 million euros per year. The new law 167 entered into force on March 2017, strongly recommending inter-regional agreements. And I'm proud to say you that today we are able to reduce the number of newborn screening centers from 32 up to 15, covering the double number of newborns per year per lab. The newborn screening is today considered not only as a test, but as a multidisciplinary and organized program, where quality is a key characteristic. Quality is not only a research option, but should insert and ruled by law. Quality means good and correct family education and information through national leaflet, if active, eventually also through regional material. Correct information means use of easy words, right information in different and most common languages. Moreover, formation, information, and empowerment are strongly recommended for families, for nurses, and also for technicians. We have a permanent school on newborn screening for technicians and chemists and biologists. We had an international school on mass spectrometry and clinical chemistry in 2018, and today a new university master for medical doctors and laboratoricians is activated. The newborn screening program consists of 3 levels: newborn screening lab, confirmatory laboratories, and clinical centers. And all of them are ruled by national law. The newborn screening lab should have specific personnel: chemists, laboratoricians, medical doctors, and also specific instrumentation and machine. The first year test should be done 7 days per week, also working in emergency. First year test should be coupled to second year test when available, because all newborn screening programs could generate false positive results. And false positive means parental anxiety and associated cost increase. And the coupling of first-year and second-year tests improved the specificity and the positive predictive value of the system. Confirmatory labs should work 24 hours, 7 days per week, and also they should operate in emergency regimen. Both labs, newborn screening and confirmatory labs, should work in quality by performing quality control and proficiency testing, national and international, and also clinical center for newborn screening should be ruled by law. The last slide for you for today is the future perspectives in our countries and the national expansion of our panel for SMA, severe combined immunodeficiencies, and some lysosomal storage disorders is under evaluation by a specific Minister of Health committee, and in the next future, disorders should be added to national program. Thank you very much, and I leave the floor to next speaker, Dr. David Shillan. Thank you very much.